Good morning, ladies and gentlemen. This beautiful New York morning is the 160th scientific meeting of this center. Believe it or not, 160th. The 161st is on the 4th of February. Rodolfo Linas is speaking then, and he's speaking on something to do with consciousness, I guess.
Psychotherapy and changes in the brain.
Wow, psychotherapy and changes in the brain. So that's going to be a stretch. Why I say who's speaking in February is to remind you that we normally have scientific rock stars presenting here. Today we have a future rock star presenting, and he's a future scientific rock star and a current clinician, which is the other thing that is unusual about today's presentation. It's going to be more clinically and practically oriented than is the norm for us. I'm very excited about it, very much looking forward to a presentation by David Schab, who trained in medicine at University of California, San Francisco, and won all the prizes for being the cleverest. And then did his psychiatry training here at Columbia University, which is where he's still based now, and his psychoanalytic training at the Columbia Psychoanalytic, which is the other place down there, up there. I know that I don't need to tell you what he's going to be presenting to us today, and I'm sure that you're all looking forward to it as much as I am. So please welcome David Schab.
Thanks, Mark. Okay, thank you for coming. I'd like to start a conversation about the effects of medication on the mind and its dynamics, and the language that we use to convey our hopes about those effects. I'd like to do so by sharing some notes and some thoughts about this issue, and also by reviewing how other people have thought about this. Just to prepare you, let me tell you what I'm not going to talk about. I'm not going to be talking about psychodynamics in the sense of how they get represented through the choice of to use medication in a treatment, and what the meanings are to the various parties in the treatment that they assign to the taking of medication. I'm going to be talking about what these chemicals do to the mind, and including what do they do to its dynamics, and the forces that maintain those dynamics, and especially how we describe those dynamics and how we integrate them into our treatments.
If you're more comfortable, you can take the mic out and just hold it.
Yeah, we try to do that.
Make sure you speak right to the top.
Okay. I'm afraid of losing my voice, so the microphone will be important to me today. By mind today, when I use the word mind, I just mean the repository of postulated psychological entities like the ego and character structure and memory and fantasy. So I'll use the word mind as shorthand for all that. And I'm also not really going to address the mind-body problem per se, at least not in the way that you all normally have it addressed in this forum. And finally, I'm going to talk as if we're talking about split treatments, in which the therapist and the prescriber are separate people, because split treatments have the advantage of forcing us to share our thinking with each other. But everything I say also applies to the internal dialogue of the psychiatrist alone, who will usually do prescribing by himself or herself. Okay, so why, as clinicians, do we care about the effects of medication on the mind and its dynamics as opposed to its effects on the brain? Well, I care for the same reason that I care about the effect of psychotherapy on the mind. I don't think of myself primarily as an enhancer of limbic transmission or a raiser of serotonin levels, but as someone who helps people feel less constrained by their conflicts, less ruled by their unconscious fantasies, and less tortured by their paranoid projections, for example. Now, kind of a relatively remarkable thing has happened in the clinical discourse about research on our treatments. Just take a look at this table, where I've organized the targets of research into treatments. Psychotherapy has always been characterized as acting on the mind. That's not a surprise, and that's what we mean when we say that our treatments change character structure, or make the unconscious conscious, or replace ego with id, or unfuse or refuse object relations, or what have you. And we have research to show these mind-based changes to some degree, like the changes we see in reflective functioning scores following mentalization-based treatments. And in the last decade or so, and very much because of the work of some of the people in this room, the effects of psychotherapy on the brain are also being investigated. And so when we look like, say, Andrew Gerber is doing in Columbia, when we look radiologically for representatives of transference in the brain, we are studying the effects of psychotherapy on the brain. And then there's the effect of pharmacotherapy on the brain. And when researchers radiolabel neurotransmitters or neurotransmitter receptors, or measure the size of the hippocampus following treatment with Prozac, they're studying pharmacotherapy's effects on the brain. Okay, so what about the effects of pharmacotherapy on the mind? Well, surely we need to convey something about a medication's effect on the mind when we say a medication is an antidepressant, or an anxiolytic, or a stimulant, or antipsychotic, or what have you. But that's deeply unsatisfying for any number of reasons. And let me say that one of them is that as therapists and analysts, we're used to acting on people's minds through experience and experiences. Now, I'll pause for a moment to describe why I emphasize experience. Two people meet and imagine that something rather momentous is supposed to happen between them. The two of you are going to change this person, or at least make the possibility of change possible. And that's really kind of incredible, because there's a lot of things militating against change. There's genetics, there's habit, there's habit that's intertwined with epigenetics, there's masochism, there's narcissism, there's secondary gain from symptoms. And then there's the environment of several kinds, the internal environment and the external environment. So, for example, there are dozens of biological forces that are indifferent to one's mood and character structure, and many of these forces are keeping up a homeostasis against any neurochemical change. And then there's also the homeostasis of your environment. If your wife married you because she likes tepid types, and your boss hired you because he recognized that your docile nature would never threaten his dominance in the workplace, then you really have nearly immovable forces militating against any kind of change. And there's just an awful lot working against resolution of your inhibitedness. So I mentioned this to say that while psychotherapy can do an enormous amount of lifting, we mustn't be ashamed to muster other resources in its aid, even for seemingly minor conditions which are stabilized in these unshakable homeostases and equilibria. Okay, so let me return to explaining why I feel, why I suspect others feel unsatisfied about what we hope for in a medication, whether we prescribe it ourselves or ask a colleague to do so, and how the issue of experience that I just described fits in. I'll get back to that. So let's say you have in your office an inhibited accountant who has a depression of some kind, or feels depressed. He ascribes his depression to failure to be promoted, or failure to promote himself, and to be passed over for promotion. You evaluate him, and you share your diagnosis of major depressive disorder, or masochistic personality disorder, or what have you, and you offer him psychotherapy or analysis or whatever, and you say, we're going to do this once or twice or 4 times a week, and this is going to make you better. Well, when you offer psychotherapy to the accountant, you're also offering him a kind of experience that you expect is going to change him. And I would say this is especially true, by the way, when we offer analysis, and I think it's something that makes analysis most different from the other psychotherapies. It's more clearly an offer of a particular kind of experience than the other psychotherapies. And maybe that's an experience of a new mode of connectedness, or the experience of calm and unfortunately guilt that comes with recognizing the wholeness of other people's inner lives. Or maybe it's the experience of embracing some rejected aspect of oneself, or an experience of tolerating rather than obscuring some longing. But whatever the ego-psychological language, or object relations, or intersubjective language, or cognitive behavioral language you use, our most successful treatments involve the offer of a new experience that will leave, in this case, the accountant with a new way of being and reacting and relating. Okay. So while our eye is on that goal, the arrangement of a new experience as opposed to delivery of a particular treatment, it seems most accurate to think of ourselves as experienceologists rather than psychotherapists. And as experienceologists, we like medication to be more of the same, to have left the patient with a history and a passage through some gates that can secure the gains of the experience. And we'd want a base of knowledge addressing how we'd like medication to fit in and promote that kind of experience. And we'd especially like, when we call a colleague or just speak to ourselves, get some water, sorry. I've got it right here, okay. Oh. Okay, so we want some kind of base of knowledge that we could use to help us say what we'd like medication to do, above and beyond just making a person undepressed or unanxious, or simply just merely stimulating the mind-body interface in some vague way. Well, so how do we do that? Well, we can try to consult discussions about the mind-body problem, which typically end up by saying something to the effect of, medications exert bottom-up or brain-on-mind influence. But that point is of no use in the consulting room. You still don't know how you expect your medication to help your colleague's psychotherapy along, or how your theory about her therapy works will help guide selection of medications. So let me bring up here 5 applicable languages that are of various usefulness. Each of these captures something about our hopes for what medications might do, especially in the context of a psychotherapy. And each of these languages makes a different case for itself in terms of its scientific basis, its heuristic value, and its applicability to thinking about our patients' minds. And after I talk about these, I'll outline a clinical case that illustrates some of the problems of picking between these. So we'll talk about medications as products, as facilitators, as tonics, as trait or module modulators, and as ego agents. Okay, let's start with products. This is the language that we use, or are usually using when we speak of antidepressants, or antipsychotics, or stimulants, and hypnotics, and so on. This is something of an anti-mind language, which is mostly, but not entirely, criticism. And it's a language that's very alluring for reasons I'll go over. The language itself, especially the word antidepressant, exerts, I think, a kind of influence on the prescriber to think of his patient's problems as something that this particular material or product reverses. In the case of antidepressants, that something is depression. And we end up in a vicious circle where we're motivated to find and name conditions depression because there's something in the material world, a product, an antidepressant, that reverses it. Now, that's perfectly okay, I think, in most cases, or many cases anyway. And maybe it's a really good thing. Just the existence out there in the ether of this very tool whose very name screams out for you to find a use for it. It's not just a hammer looking for a nail. It's an anti-nailant looking for a nail. And the energy in the name of that category, antidepressant, and probably in the most energetically named brands like Prozac and Wellbutrin and Lexapro, I think productively presses us to give up our dithering and to get on our patient's trouble right away. Because something can be done about it right now. And besides, who isn't vehemently anti-depression? The trouble is that this language nudges us away from exploring how things got to be this way for the patient and what meanings the patient is making of this experience and what meanings of his might be maintaining the experience and so on. Again, this may be okay. And getting someone much better now has infinitely greater value than resolution of our philosophical values. The problem is, these are not just philosophical issues. When we employ this language of products, we are inadvertently suggesting that what the patient has experienced is meaningless. The language of these products, and please make sure you hear me criticizing the language. I'm not designing an apology for withholding these products. The language of these product categories and just their mere availability and the name conveys that what's happened to you is foreign and an exception or a kind of meaningless disturbance in the continuity of your life, not something you might grow from or learn from or make something useful out of. And we tell the patient and ourselves and whoever we're collaborating with in the treatment, such and such has a categorical problem that goes away with a categorical product. And whatever psychotherapy or self-reflection might go along with the medication can end up being demeaned as just window dressing. Now, the allure of this language and thinking comes from all kinds of sources. And the biggest is that it's tied to a deeply inculcated scientific framework that says there is a categorical disease, namely serotonin deficiency or some other neurotransmitter deficiency, and that this product category will reverse that. The framework is formally known as the monoamine hypothesis, and it arose from findings in the 1940s and 1950s that drugs that depleted serotonin and norepinephrine caused depression, and that drugs that increased the availability of those chemicals in the brain treated depression or caused mania even. And then through some thoughtful backwards reasoning, it was determined that depression was caused by insufficiency of those chemicals, those monoamines. This led to our current panoply of antidepressants, which raise monoamine levels. Some more selectively increase serotonin, and some more selectively increase norepinephrine. A few slightly affect dopamine. On this slide, I've arranged common antidepressants according to which neurotransmitter system they affect. Some of the drugs in here work through additional mechanisms, but they all have properties that allow them to loosely fit here. So in this top line here, I have the tricyclics. Pimipramine is ostensibly a serotonin drug. At that end, nortriptyline and desipramine are ostensibly noradrenaline drugs. The other tricyclics fit somewhere in between. The serotonin reuptake inhibitors, well, they fit under the serotonin category. The norepinephrine reuptake inhibitors, we don't, in the United States, we don't really have, except for. Oh, sure. Thank you. Yeah, thanks. Yeah.
The furthest forward button.
Great. Great. Thank you. The norepinephrine reuptake inhibitors, we don't really have any here in the United States except for an ADHD drug known as Strattera, atomoxetine. But in Europe, they have others, reboxetine, Europeans, that is a drug Europeans prescribe. And then in the middle here, we have the serotonin, norepinephrine reuptake inhibitors. These are things like Effexor and Cymbalta. Mirtazapine is a tetracyclic drug, Remeron, and then there's the monoamine oxidase inhibitors. And these drugs all affect both of these major categories of monoamines. Now, after antidepressants raise monoamine transmission, there are 1,000 biological theories of what happens next. And many of them are built around explaining the long delay in efficacy of these drugs. Things like changes in the sensitivity or function of the monoamine receptors, but also GABA receptors and glutamate receptors, and beta receptors, and also changes in immune function and inflammation pathways. But you can recognize any of these theories' fidelity to the monoamine hypothesis by their assumption that monoamine deficiency is the or a source of depression. And these theories were conveyed to us at a time when we were becoming doctors or forming our identities as people who treat diseases. And these theories or all of this gets reinforced by a lot of marketing. So many of you will recognize that your patients even subscribe to the monoamine hypothesis when they ask you about serotonin deficiencies and so on. But the main point here is that when we speak of these products, we're quietly referencing and leaning on a fraught scientific framework that adds allure to a very particular language with its own problems. Okay. Okay, so now we'll move on to another language, another model. Facilitators. It's a bit more satisfying because it speaks more to what we may think we may be doing to a patient's mind in psychotherapy. It's medications as facilitators, and it's a language or theory that we're most aware that we're using when we're thinking of a patient who's in psychotherapy. And we're quite explicit about it when we're talking with our colleagues in collaboration. It's the implicit theory we have when we think to ourselves or suggest to our colleague that reduction in a patient's anxiety or improvement in his mood will support a therapy. We think that reduction in single anxiety or reduction in rumination will support the therapeutic process. Whatever our true therapeutic orientation, I think most of us are at least superficially being ego psychologists at that point in these situations, because we think that anxiety or really defenses against anxiety are tripping up progress in the therapy or in the patient's growth outside the therapy. The distinguishing feature of this language and framework is that while we may be hoping to directly make the patient feel better, we're also hoping to facilitate some process that will keep the therapy or the patient's emotional development running along. Now, aside from reduction in anxiety, this can mean reduction in other affects that are obscuring life and therapy. The American Psychoanalytic Association's textbook of psychoanalysis cites an article by Arnold Cooper in which he expresses regret for not starting medication sooner in an analysis. And the quotation is a nice place to begin thinking about this. Retrospectively, pharmacological assistance earlier might have provided a much clearer focus on her content-related psychodynamic problems and would have made it more difficult for her to use her symptoms masochistically as proof that she was an innocent victim of endless emotional pain. Cooper's sentiment, I think, hints at, or at least stirs up the thought that medication might have afforded the patient a different and ultimately mutative experience of herself. Here I'm getting back to the experience issue that I belabored so much earlier. Let's imagine for a moment that this patient's central problem was that she was only capable of and only familiar with sadomasochistic attachments. Let's further imagine that reduction of punitive feeling, either toward herself or toward her intimates, would make such sadomasochistic attachments harder to form and harder to maintain. And then finally, let's imagine that we believe that medication can do this, either by increasing positive affect or reducing negative affect. In my fantasy of what Dr. Cooper would then have gone on to say, had he been helping me with my talk, then the passage might have continued in the following vein. Once the medication took effect, she would stop torturing me and her intimates, and she would see that she could bond with me through positive, non-masochistic and non-sadistic interactions. By enabling at first a conscious memory and then an implicit memory of this new kind of connection, the medication would have helped usher in a new mutative experience and paradigm. This new paradigm would at least compete with or hopefully replace her old interpersonal sadomasochistic paradigm. Okay, so that's medication as facilitator of mutative experience. To the degree that this is what we want for our medications, the model is nice because when deciding whether and how to medicate someone, it forces us to think about what other processes, other psychotherapeutic or others, we might be able to enhance with our choice. Okay. Now we're going to come to the tonic language. That's the third one. Now on the surface, this should sound unfamiliar to you, but I think it arises from a model that we all covertly use without realizing it, as I'll explain. The language is a slightly more European heritage, and certainly a heritage in older psychiatry. By tonic, I don't mean something that necessarily stimulates or invigorates, but though it usually may do that. I mean something that, once ingested, kind of colors the organism's feeling state or drive state. You can actually think of tonics as drive agents. And you'll see such terms in old pharmacology textbooks. Though I don't think writers were thinking and using the thinking, I don't think writers were thinking about drive the way analysts would. Authors typically adopted the words from animal physiology research, like that of the physiologist Walter Hess, who devised two words to denote anatomically distinct subcortical systems. These are the two systems, the ergotropic and trophotropic systems. He described an ergotropic system that included the sympathetic nervous system and prepared an animal to expend effort, and a trophotropic system, which included the parasympathetic nervous system and other subcortical systems that prepared an animal for eating and sleeping and other recuperative activities. I don't know when these words got introduced into the psychiatric literature, but they were already being used in this misspelled and etymologically mixed up way as ergotropic, work eating, and trophotropic, eating. In the 1960s, in papers by the prominent monoamine chemist Bernard Brodie. This is a chart from one of Brodie's articles. Near synonyms for ergotropic were dynamogenic and power-making and thymoretic. Loosely means mood or drive enhancing. Anyway, so this is a chart that Brodie used to summarize Hess's thinking. And Brodie believed that the future of pharmacology was in the development of either norepinephrine drugs, which would act on the ergotropic system, and serotonin drugs that would act on the trophotropic system. And I think it's worthwhile only just to eyeball that first row of data to get a sense of what these systems were said to be responsible for. Okay. Okay. Now here's the first of two slides illustrating a kind of a trivalent version of that same kind of thing, but this time incorporating dopamine. These are from a pharmacology textbook with lots of personality called Differential Effects of Antidepressants by Brian Leonard and David Healy, the provocative historian of psychiatry whose influence on me you may have recognized in my discussion of medications as products. But as you look at this, all you want is a sense of the thinking reflected in the slide. Don't try to learn anything from it. No. I mean, you're welcome to, but the point is just to give you a feeling for the kind of thinking reflected here. And here's another similar slide. Here again, you see these words, though misspelled or misused, ergotropic and tropotropic. Okay, I'm going to show you one more slide. Okay. Let's see. This last one's taken from the work of a Swiss psychiatrist, Paul Kielholz, from the 1960s. And it illustrates Kielholz's ideas about how you might select medications depending on what you wanted to do to a person. And how you might make a more attuned selection of a medication. Pay attention mostly to these hatch lines here. Those bars with the hatch lines are illustrating that those medications on the left, the MAOIs especially, but also dicipramine and nortriptyline, are Antriebsteiger, or drive-enhancing, drive-raising. And those on the right are Dempfid, or dulling. The fundamental feature of this model and language is that they make relatively broad claims about what medications are supposed to do. Before a categorical model of mental illness got hold of diagnosis, this language and this sentiment, the sentiment that you want to make your patient a little more this or a little more that, was openly acceptable. And it's a dimensional system of treatment whose application maybe seems a little less obvious or less obviously applicable in a categorical system of disease. But I think that this is a model that a lot of us unwittingly use when we talk to each other on the phone and say, you know, such and such seems to have no drive, no oomph. Maybe you could give him a little something to turn his mojo back on. We don't, therefore, of course, say, oh, give him an ergotropic or give him a thymoretic. But still, the sentiment is implied. And you know, as a more specific example, when a colleague maybe suggests to me that I consider prescribing a stimulant or Wellbutrin to her languid, torpid patient. Occasionally that works. But the model or language has a lot of risks. And it risks confusing our ideas of what the medications do with what the underlying problem is. If you don't form some dynamic picture of your patient's mind, you can make a real mistake with this model. So, for example, if you attend only to your patient's passivity and languor, you may overlook that their source is actually very, very active, inner-directed anger and self-punishment. And so if you try to attack the passivity and languor with, with a drug that you think of as kind of work-enhancing, effort-enhancing, an ergotropic drug, an Antriebsteiger drug, or a thymoretic, you may end up just fueling the anger and self-punishment and actually then worsening the passivity and languor. Okay. Now I'm going to talk about a fourth language. And it's an approach that says that there are not broad, but rather narrow, fundamental things wrong in our temperament and personalities and style, or attachment systems that we might target with medication. I've picked the language of the psychiatric geneticist Robert Cloninger because I was somewhat familiar with it, and because treatments have been tested that grew out of his approach to carving up human nature. But after that, I'll point out that Dr. Panksepp focused more on affect than on personality, carved up nature a little differently than Cloninger did, and has proposed his own directions of treatment that follow similar strategies. Okay. Now, Cloninger was originally trying to predict vulnerability to mental disorders and proposed these first three temperament dimensions, and later this fourth one, persistence, thinking that these four dimensions would help with predictions of vulnerability to psychiatric illness. And these temperament dimensions were thought to reflect genetic layout of deep and midbrain structures. And later he tried to build models that incorporated more than genetics. So these models began to incorporate epigenetics and neuroimaging and neurochemistry. He moved, like I said, from the first three to a fourth dimension. And then, trying to account for all the variability in personality, he added these three character dimensions, for which he proposed no specific neurobiological underpinnings. The personality was, in this model, constructed from these four temperament dimensions and these three character dimensions. At the end, if people are curious, we can go over what he meant by each of these 7 factors. Their names don't really do justice to what the dimensions are meant to capture. But temperament, he believed, was the imprint of genetically informed biases that act automatically and unconsciously, or in some cases, preconsciously, and create a background of automatic response to stimuli. Character, on the other hand, arises from interaction with the environment and describes how individuals govern their emotional conflicts. Character is more malleable, it's more software-like. So working with temperament dimensions alone, Cloninger mapped out all the combinations and permutations of high novelty seeking, low harm avoidance, high reward dependence, low persistence, and so on and so forth. He mapped these all out onto, at the time, DSM-3 personality types. And if you had high novelty-seeking and low harm-avoidance scores, and so on, you had one kind of DSM personality, and so on. But ultimately, more variability in personality could be explained once these 3 character dimensions were included. Now, other dimensional systems compete with and perhaps have superseded Cloninger's, but I bring up Cloninger's because it was the first one that led to a clinical language that addresses the forces and balance of forces in our minds that might help select medication. So Peter Joyce in New Zealand was the first one, appears to have been the first one to have done this in the 1990s. His group administered Cloninger's tri-dimensional questionnaire. So this was at a time when Cloninger was only working with the first 3 temperament dimensions. They administered this tri-dimensional personality questionnaire to a whole bunch of subjects, and then it scored them, and then randomized them to receiving either desipramine, right, an essentially noradrenergic drug, or clomipramine, which is an essentially or ostensibly serotonergic drug. And they found in general that temperament predicts about 35% of variance in success of outcome. In fact, among the most depressed people, it accounted for 50% of outcome. Most importantly, though, among women, was that those with high reward-dependent scores responded better to clomipramine, and those with high harm-avoidance scores responded better to desipramine. And similar research from other groups found that various personality factors not only predicted response to particular antidepressants, but also that various personality factors were themselves differentially responsive to different antidepressants. So this kind of approach could be really useful, assuming we could judge temperament and character and personality without having to administer unwieldy questionnaires. The therapist, who knows the patient very well, and the psychiatrist could decide together whether their patient has, first of all, has the kind of temperament that would respond to antidepressants in general, and if so, which one? And just having this possibility that personality might help predict medication choice would put a real premium on us to do the best job possible in characterizing our patients' personalities. So this is one way, actually, that the availability of medications could force us to be even better dynamic diagnosticians. So this would be especially true if somebody could figure out how to parse humanhood into particularly meaningful units that would have more predictive value than Cloninger's. He was focused on dimensions of personality, And it may be that Dr. Panksep's focus on affect and his 7 proposed affect systems would make a more natural parsing of what's behind mood disorders. Dr. Panksep and others have suggested that we'll have drugs that act on these 7 systems one day. But before that time comes, we should probably be ready to think and talk about dimensional characteristics and modules that we'd like to pharmacologically adjust. Okay, so now we get to the last of these languages, which I think will sound the most mind-oriented. And this is the ego psychology language of Eric Marcus, who's the director of the Psychoanalytic Institute at Columbia. He starts with a model of the mind that emphasizes mental structures. A mental structure is a semi-stable apparatus that generates all the patterned reactions that we say makes up a person, or at least his personality. It's something inferred from these patterns. It's not a physical thing we can see. And the concept of mental structure shows up in pretty much all models of the mind, but Dr. Marcus's is one that's an unabashedly ego-psychological model. This means he starts from the assumption that there's not merely an organization or structure of the mind, but an apparatus whose function is to actively maintain organization and stabilize structure. And that apparatus is the ego. And among its functions is a highly active maintenance of boundaries between itself and the id and the superego, also between affects and systems of perception, and between affects and ideation, between systems of perception and systems of ideation, between the unconscious and the conscious, and between fantasies and reality, between representations of inside and outside, and between object relations, and so on and so forth. The ego aggressively maintains boundaries between all of these. So let me start by describing something from the psychotic realm. Let's say your boundary between your sensory or perceiving apparatus and your affect system is no longer maintained, either because of something afflicting the boundary itself, or because of some direct assault on the ego of some kind, which is supposed to be maintaining those boundaries. Then your affect, your fearfulness, that is, colors your perception of that black livery cab outside your apartment, and you have the illusional experience that it's an FBI car following you. And if the boundary between your affect system and your ideation system is disturbed, then your fearfulness disturbs your thinking about all this. And you have the delusional experience that the car is part of some kind of greater persecutory experience. And if the boundaries between object relations is disturbed, you might believe that the driver and your father and God, or some fusion of the three, have pulled up in that car outside of your apartment to destroy you or save you, or some combination of both of those. Certainly a combination that seems more confusing to you than to your patient. Of course, his mental apparatus is now structurally different from yours, and so it doesn't flag things that seem inconsistent or paradoxical or and impossible to you with your intact ego apparatus and intact boundaries that normally keep categories of experience separate. So, in this view, when we prescribe an antipsychotic, we're resurrecting all those boundaries. And it's just what our colleague would be doing in psychotherapy. Let me reiterate for a moment now. Psychosis here arises because the ego is no longer maintaining these boundaries, either because the ego is weakened or overwhelmed, say by overwhelming affects, or because the boundaries that it normally maintains crumble beyond its capacity to repair them. Affect can do this, and of course organic disease can cause all these kinds of problems. And just to be clear, this thinking also applies to non-psychotic states too. which brings us to the more common situation of maybe of a therapist and a psychiatrist collaborating in treating a moderately severe mood disorder or a personality disorder with depressive features. In these cases, Marcus's view is that mood colors the content of thought, and as mood is essentially the background of mental functioning, as he puts it, excess affect can easily unseat the patient's autonomous ego. And so unseated, the ego can't keep mood in its place, and mood begins to color everything, including content and perception of reality. And disturbed perception of reality, for example, gives you affect-driven hopelessness, which is not something we normally consider psychotic. And mood run wild like this also leads to disruption of the ego's defenses. Normally flexible defenses become rigid in the face of overwhelming affect, and so obstruct reality testing, as well as observing the ego. Let me give you a little metaphor to help describe that. Defenses in this model are a little bit like silly putty. Silly putty is a so-called non-Newtonian fluid. If you squeeze silly putty with just a moderate amount of pressure, it adapts and cushions the squeeze as it flexes, like a viscous fluid would. Healthy defenses adapt like that, like silly putty that's been pressed gently. But if you squeeze silly putty extremely hard and fast, it inflexibly pushes back like a rigid solid. Actually, if you strike silly putty with a hammer, it will shatter. So defenses that are forced by powerful affects to be this rigid keep a person relatively unhappy and make psychodynamic psychotherapy nearly impossible because observing ego is lost. And any way that the prescriber can reduce the affective pressure on this non-Newtonian defensive system can help defenses go back to their work of being flexible and adaptive and even helpful. And psychotherapy can proceed. What's nice here is that Marcus makes it very clear what mood does and what you as a clinician need to do back and why you need to do it, with medication or otherwise, above and beyond just resolution of suffering. Whether you're talking about psychotherapy or whether you're talking about medication, you need to restore the boundaries between categories of experience, and you need to restore the ego's opportunity to heal boundaries by reducing the affective pressures that it has to contend with. As a final point, let me also add that his ego psychology also makes sense of other medications too. Stimulants, for example, in his view, taken by normal people, kind of rev up the ego and all the mental agencies so that defenses get intensified, and categories of experience that the ego normally keeps separate become even more rigidly quarantined. That's the opposite of the ideal condition for creativity, which requires cross-linking of modes of experience. And this is, by the way, very similar to what Dr. Panksepp says about stimulants as anti-play drugs. Okay, so what have we done so far? We've touched on 5 different ways of thinking and communicating to each other about what we hope medications will do and how we think they'll fit into psychotherapies. I think rather than summarize all these, I'm going to outline a case for you that made me think about how much and how little guidance these languages and models give me when I'm collaborating with a colleague. So, a psychologist sent me Susie, let's call her, and I'd say she's a corporate lawyer in her low 40s with a history of unstable mood and impulsivity and mild impulsivity and relationship troubles. And a variety of other symptoms of a borderline character structure. Susie's highly idealized boyfriend was clearly breaking up with her at the time. And Susie's chronic self-esteem and sleep problems, both of which had been better during the relationship, had begun worsening. Now, my colleague started psychotherapy, and the psychotherapy initially focused on Susie's idealized picture of a doting father, who really, in fact, sounded much more like he was much more consumed with his narcotics addiction than he was with his daughter. So the psychotherapy sought to heighten Susie's awareness of the connection between her self-esteem and the perceived or misperceived availability of some idealized doting man. Susie slowly got this, and she added all sorts of rich details to her therapist's points, and she really seemed viscerally touched by my colleague's emphasis. Her mood even improved. But she kept coming back to how she would get her boyfriend back. By losing weight, by quitting smoking, by getting her mood better with therapy or medications or what have you. And whenever he came up, her longing just overwhelmed her ability to reflect in the therapy. Now, Susie saw a psychiatrist before me, and he got her onto 2 middling doses of 2 antidepressants before she dumped him. And she dumped him for suggesting that she was suffering a broken heart. And I think thereby implying that she might have to let go of his boyfriend, who had made it very clear that he was done with Susie. So then when I saw her, in addition to some of the things I've told you, I learned a couple things. I'm just going to tell you what a few of them are. Susie was not a drug user herself, but many members of her family were outright narcotic addicts. It was not just her father. And there was also a spattering of schizophrenia and other psychotic disorders in the kind of margins of her family pedigree. And so I found someone here in front of me, someone with low self-esteem, some moderate triphasic insomnia, but really no other vegetative symptoms, and substantial worry about how to get her boyfriend back. I'll skip diagnosis for a moment and just say that I conveyed to my psychologist colleague my impression, and my colleague concluded our conversation by adding, I think quite rightly, that Susie cannot function without the fantasy of getting her boyfriend back, and that she can't really participate in an exploratory psychotherapy if her thinking remained this rigid. So, thinking about the patient and my conversation with her psychologist, I imagined, or at least have subsequently imagined, how these 5 languages I've talked with you about did inform or could inform my treatment. In the framework of the product language, I might see her as having a depression with a capital D, and I'd write her a prescription for an antidepressant, maybe a serotonin drug or some mixed mechanism drug that might also help with her sleep right away. Okay? And then in the framework of medications as facilitators, I might see her anxiety about loss of the boyfriend as being the central thing that was obstructing her psychotherapy. And I would therefore prescribe an antidepressant, maybe also benzodiazepine, like Ativan or something. Or I might see her nearly psychotic rigidity as interfering with the psychotherapy. And in that case, I prescribe a low dose of an antipsychotic. The tonic framework that we talked about, the tonic is maybe less helpful here, but one could argue that she had insufficient drive to seek out new and competing experiences to fill up her time, to fill up her mind, and maybe find a new boyfriend. Or conversely, one could argue that her drive was overactive, and that she needed one of those antidepressants or antipsychotics that was on the right side of Paul Kielholtz's chart of drive agents. One of those drugs that was drive dampening. In the kind of Cloninger and dimensional model, maybe her reward dependence was what needed modulation with maybe a norepinephrine or dopamine drug. Or maybe her persistence dimension needed treating with some anti-compulsive drug, like an SSRI or clomipramine. Okay, or this is from one of Dr. Panksepp's articles. So a la Dr. Panksepp, maybe I should treat her panic and separation distress. Right here. Her panic and separation distress system with some modulator of opioids or oxytocin or prolactin or cortisol releasing factor and so on. Or maybe her panic and separation distress system was working just fine, and maybe it's her seeking system up there at the top. Maybe it's her seeking system that won't shut off and allow an outright painful but otherwise resolvable mourning process to set in. In that case, then maybe she needs some kind of opioid and neurotensin modulators to turn off her seeking system and allow a depression to arise and resolve. That last approach, by the way, would also be honoring the addictive aspect of Susie's distress that was suggested by her family history of narcotics addiction. And by the last framework, the ego agent or ego psychological framework I presented, we would have two possibilities. We could treat the affect that's overwhelming her ego and upending her capacity to reflect. We would do this with an antidepressant, maybe, or mood stabilizer, depending on the situation. Or we could decide that her trouble is the crumbling boundary between her affect, namely her longing for this boyfriend, the boundary between that longing and her thinking. In which case we would restore that boundary with an antipsychotic. So, okay. I'm a clinician, and I hope I've conveyed just how uncertain a position I'm in when I'm prescribing for my own patients and for those of my colleagues. And of course, I've simplified things by excluding all the psychodynamic considerations that go into even deciding whether to use a medication. And I've simplified by excluding, all the complications that prescribing makes for the relationship with the therapist and the prescriber. And I've simplified by suggesting that there are merely these 5 prescribing languages. And there's certainly many more languages and models that we all can probably think of in here. I don't know how to navigate these models any more than I know how to navigate all the psychoanalytic theories that were taught in our psychoanalytic institutes. Except to say that a plurality of theories and a polyglot approach makes us readier to identify elements of our patients that we'd otherwise miss without some preformed idea of how clinical data arranges itself. But if the goal of science is to unify theories rather than multiply them, embracing this plurality of theories is a distinctly unscientific view. But it's counterintuitively useful because it expands possibilities rather than simplifying them. So, such are my experiences and thoughts from my limited perspective as a clinician. And I'd like to open up the discussion to all of you, and from the very different positions that so many of you occupy, and hear about how we might arrive at a more productive discourse about all these issues. What steps we could take to get there, and also what impact it would have on the kind of work that you all do.